So in this short tutorial we will discuss about ABG. Okay? So in ABG there are different states. State number 1, you have to see pH. So state number 1 is pH. After pH, step number 2 is PCO2 and bicarbonate. Okay? So if the pH is normal, it doesn't mean you are not having any acid-base disorder. So if pH, PCO2 and bicarbonate all are normal, then you will say the subject is not having any disorder. Okay? So pH, normal pH value is 7.36 to 7.45. If the pH is less than 7.36, it is acidosis. And if pH is greater than 7.44, it is alkalosis. Then you have to find out whether this acidosis is metabolic or respiratory. So how you will say acidosis is metabolic? When there is decreased bicarbonate. Less than how much? Less than 21. Okay? If bicarbonate is less than 21, it is metabolic acidosis. How you will say respiratory acidosis? If the PCO2 is greater than 44. Okay? This is metabolic acidosis and respiratory acidosis. Then coming to the alkalosis. When you will say metabolic alkalosis, if the bicarbonate is greater than 27, then it is called metabolic alkalosis. And what about respiratory alkalosis? If PCO2 less than 36, then it is called respiratory alkalosis. Now till now we have covered what is less pH is called acidosis, what is alkalosis, what is respiratory acidosis, what is metabolic alkalosis, what is respiratory alkalosis. Now, so step number 2, till now we have covered. Step number 3 is you have to find out the hidden disorder. That means step number 3 is for compensation. And for compensation, you should remember the Henderson-Hasselbalch equation. H is equal to 24 into PCO2 upon bicarbonate. And what is the meaning of compensation? Compensation is always parallel. Compensation is always parallel. Means what? If PCO2 increases, then bicarbonate increases. If PCO2 decreases, then bicarbonate decreases. If bicarbonate increases, then PCO2 increases. If bicarbonate decreases, then PCO2 decreases. So if PCO2 increases, then bicarbonate increases, then it is called compensated respiratory acidosis. See? If PCO2 decreases, bicarbonate decreases, then it is called compensated respiratory alkalosis. If bicarbonate increases, then PCO2 increases, compensated metabolic alkalosis. If bicarbonate decreases, PCO2 decreases, then compensated metabolic acidosis. Okay. So step number 1 is you have to see the pH. Step number 2 you have to see whether metabolic or respiratory acidosis or alkalosis. Step number 3 is you have to find out the compensation, and compensation is always parallel. Then you have to find out how much compensation it is. So for metabolic acidosis, expected PCO2 is equal to 1.5 into bicarbonate plus 8. Means for metabolic acidosis, what is metabolic acidosis? Decrease in bicarbonate. So how much PCO2 will decrease from normal? Then only you will say compensated metabolic acidosis. So this is expected PCO2. Second is for metabolic alkalosis, expected PCO2 is equal to 0.9 into bicarbonate plus 16. So what is compensated metabolic alkalosis? Metabolic alkalosis, increase in bicarbonate. So expected PCO2 will increase will be how much? How we will calculate? We will calculate by 0.9 into bicarbonate plus 16. Then for respiratory acidosis, so in case of respiratory acidosis, per 10 mm rise in PCO2 corresponds to 1 millimole per liter rise in bicarbonate. Then it is called acute compensation of respiratory acidosis. Means suppose if the normal PCO2 is 40, if the PCO2 increases to 50, then bicarbonate should increase by 25. 24 is the normal you are taking, and if it is increased by 1, then it is called acute compensation. Then for chronic compensation, per 10 mm rise in PCO2 corresponds to 3.5 millimole per liter rise in bicarbonate. Means what? If the PCO2 increases from 40 to 50, and when you will say chronic compensation, when bicarbonate increase by 24 to 27.5. Okay? This is compensation for respiratory acidosis. For respiratory alkalosis, alkalosis is what? PCO2 decrease. So per 10 mm decrease in PCO2 corresponds to 2 millimole per liter fall in bicarbonate, then it is called acute compensation of respiratory alkalosis. Means what? Suppose if the PCO2 is normal is 40, if it decreases to 30, then how much bicarbonate should decrease? 24 to it becomes 22. Then we will say acute compensation for respiratory alkalosis. What is chronic compensation? Per 10 mm decrease in PCO2 corresponds to 5 millimole per liter fall in bicarbonate, then it is called chronic compensation of respiratory alkalosis. Means what? If the PCO2 decreases from 40 to 30, the bicarbonate should fall from 24 to 19. Then we will call chronic compensation for respiratory. Now, so these are the basic steps. Now, next, what you have to find out if the case is metabolic acidosis. If the case is metabolic acidosis, then there is a question of anion gap. There is a question of anion gap. And what is anion gap? Anion gap is unmeasured anion minus unmeasured cation. This is how we can find out anion gap. As from your previous knowledge of physiology in first year, you might be knowing according to Gibbs-Dolan equation, the number of cations is equal to number of anions in any compartment. So, cations are, main cation in blood is sodium. As compared to sodium, potassium is very less. So, we will take in unmeasured cation. Sodium plus unmeasured cations equal to number of anions is number 1 chloride plus bicarbonate, and rest of the things we are taking as a unmeasured anion. Okay. Now we will rearrange this equation. So unmeasured anion minus unmeasured cation is equal to sodium minus chloride plus bicarbonate. This is the equation of anion. So, how the metabolic acidosis can be caused? What is the cause of metabolic acidosis? There can be two causes. One is utilization of bicarbonate, and second is loss of bicarbonate. So, how utilization of bicarbonate is there? If there is abnormal acid produced in the body. Abnormal acid is produced. Means what? Suppose if there is HA, is acid, it will react with water and forms H2CO3 plus A minus. So this A minus is unmeasured anion. And for that, what you are doing? We are utilizing bicarbonate. HA plus bicarbonate is equal to H2CO3 plus A minus. This A minus is unmeasured anion. And how this unmeasured anion is produced? By utilization of bicarbonate. So what will happen to the anion gap? As unmeasured anion is increased. So for anion gap, unmeasured anion minus unmeasured cation. So if unmeasured anion gets increased, there will be increased anion gap. So when the anion gap will increase, when there will be abnormal acid, when there will be utilization of bicarbonate. So what can be the situation in which bicarbonate is utilized? Number 1, lactic acidosis. Number 2, formic acid from methyl alcohol, acetic acid from methyl alcohol, oxalic acid from ethylene glycol, and last is aspirin, because aspirin inhibits electron transport chain. Because of that, the lactate is produced in aspirin. So under these conditions, anion gap will be increased. So how anion gap will be increased? Because unmeasured anion increase. How unmeasured anion increase? Because of utilization of bicarbonate. So this is the condition in which increased anion gap. Now, loss of bicarbonate can be loss of bicarbonate through GIT or through urinary system. Now, in GIT, most common cause is diarrhea. In diarrhea, mucus is rich in bicarbonate. So because at the level of enterocyte, there is a transporter, that is bicarbonate chloride transporter. So if bicarbonate loss occur, chloride will increase. Similarly, in case of urinary loss also, if bicarbonate loss occur, chloride level will increase. Now, according to anion gap formula, sodium minus chloride plus bicarbonate. As bicarbonate is decreasing, but chloride is increasing. So there will be no effect on anion gap. And remember, any condition that causes hyperchloremia, when the chloride level increases, that causes normal anion gap. Now, next is how you will identify that whether the GI loss or urinary loss. Then you will see urinary anion gap. Urinary anion gap. And the formula to calculate urinary anion gap is same, cation is equal to anion. So which is the most important cation in urine is sodium, and you cannot ignore potassium also. So sodium plus potassium plus unmeasured cation. Anion is chloride, because bicarbonate very minimal amount excreted in urine. So chloride plus unmeasured anion. And by rearranging, unmeasured anion minus unmeasured cation is equal to sodium plus potassium minus chloride. Okay? So if you have to find out whether there is urinary loss or GI loss, you will see urinary anion gap. If urinary anion gap is negative, so there is a gut, GAT gut, okay? So it is GI loss. And if urinary anion gap is positive, it is urinary loss. Okay? So this is metabolic acidosis. Now, next, the metabolic alkalosis. So metabolic alkalosis, the cause is primary aldosteronism and secondary aldosteronism. Primary aldosteronism causes sodium retention, potassium excretion, hydrogen ion excretion, so it causes metabolic alkalosis. Secondary aldosteronism, any condition that cause volume contraction, anything that decreases blood volume, that can cause secondary aldosteronism. How? By volume contraction, decrease blood flow to kidney. JG cell get stimulated and that releases renin. Renin act on angiotensinogen, convert into angiotensin 1. Angiotensin 1 get converted into angiotensin 2 by angiotensin converting agent. And angiotensin 2 act on zona glomerulosa and forms aldosterone. So, in case of secondary aldosteronism, when you will think, when there will be fluid loss. So, earlier we were having thinking that in case of vomiting, the alkalosis is because of loss of acid in the vomitus, but that is not so. It is because of the volume contraction. Because of vomiting, fluid loss is there, and in metabolic alkalosis, so you have to find out whether it is chloride responsive or not. Chloride responsive or not. So, if it is due to volume contraction, you will give normal saline. You will give normal saline. So, secondary aldosteronism is because how it will respond? It will respond by normal saline, and it is called chloride response. Okay? Quickly, we will recapitulate within 1 minute. So, number 1, you have to find out pH. Number 2, you have to find out whether respiratory acidosis, metabolic acidosis, respiratory alkalosis, metabolic alkalosis. Number 3, you have to find out the compensation. And I have given you different formula for finding out the compensation. Okay, that's. But if you are seeing the metabolic acidosis, you have to find out the anion gap. Whether it is a high anion gap or normal anion gap. High anion gap when abnormal acid is produced because of utilization of bicarbonate. But if you are saying normal anion gap means hypercholeремia is there. Okay? Then how you will find normal anion gap is because of either GI loss or urinary loss. How you will find out GI loss or urinary loss? You will see urinary anion gap. If urinary anion gap is negative as gut is there, so GI loss. If urinary anion gap is positive, it is urinary loss. And lastly, metabolic alkalosis. So, two causes, primary and secondary. Primary, saline will not be respond. Why? Because fluid volume is already high. In case of secondary, because of volume contraction, so it will respond with saline. That's it. क्या करूं?